I mean, I know I like you, Shane, because you're a straight speaker. All right, so you tend to answer a question with a proper answer instead of heading off to the horses somewhere. But one of the things that you must be thinking in your mind at the moment is, yeah, we might win this election, and you'll probably, in your mind, be quite confident about that, and you probably will be confident about being the Minister of Health. I would wake up in the morning at the moment, if I was you, with cold sweats thinking, oh my God, I will be the Minister of Health. Do you?
No, I wake up with the potential privilege and the opportunity of maybe being able to make a change. I look hard enough to have things in motion if we're successful, but actually I look at what's in front of me here today, the people who are contacting me here today saying we're struggling in ED, we've got patients here, we've got patients there. I look at that and try and do a good job with that today. But yes, of course, I future plan and think, okay, if we're given the privilege, how would we make a change? What are the key things we would need to do? And it's not just actually warm bodies, so health workforce clearly is probably our most important issue to address. But it's actually also lifting the hearts and minds and the spirits of the sector. They're exhausted. They're tired. And so we need to be thinking about how we do that as well, Michael. So, no, I wake up each day thinking, how can I do more? How can I do better? And I would relish the opportunity and the privilege to maybe being able to make a change.
All right, good on you. Now, the reason I've asked you on the show, well, there's a couple of reasons, but the primary reason is because you've been riding with St John's Ambulance folk around New Zealand, I presume, and looking at how they're coping with the emergency departments around New Zealand, and you've made some observations. First of all, can I ask you, what was the purpose or aim of this sort of project that you undertook?
So at my desk, I see people as a GP. I see what we do, obviously, and how we consult, but it's after hours. Unless I'm working in an after hours clinic, it's what happens after hours. What does the New Zealand health system look like after dark? And the best way for me to experience that was to join St John's or Wellington Free and do a night shift from 6 to midnight, or sometimes it was 9 p.m. till 3 a.m, and actually go with them and be with them when they go into New Zealanders' homes and see what the need is that's called out the first responders that night. Where was the system failing? Looking at how the first responders were distributed, looking at where GPs either were covering after hours or not covering after hours, and doing that across the whole country, in every single emergency department and in every region. So this was a 3-month body of work, almost every weekend from Waitangi Day through to Easter. I was on the ambulances doing a night shift, absorbing and looking where the holes are and thinking about how we could do better.
When you're saying doing a night shift, do you mean you were just travelling alongside them as an observer, or you were a participant in providing medical care?
So I was an observer for what they call technically as an observer. What that meant was that, of course, I would help push the stretcher into ED, and occasionally we'd talk differential diagnosis, and sometimes they pass the ECG across and say, hey, Doc, what do you think? So we would have these discussions, but my designation was as an observer.
And that required assent, I get, at a national level from St John's Ambulance, correct?
Yes, that's correct. Yep.
That's interesting that they allowed you. They organised it. Well, no, not really, because they have observers. They've had journalist observers who have done night shifts. They've reported in this past few months that they've done night shifts and how it was for them. Normally, it's a single moment in a single shift, not 3 months across all of New Zealand. But St John's and others can't recall quite a pervasive body of work where someone doing what I do has been able to join them and have a good look at what happens. It's a disastrous system. I'm sorry, I've served on a district health board for 3 years. I do not understand why St John's Ambulance is not fully funded by the New Zealand Public Health Service and exists in that sort of hybrid world out there. Why do they exist in that hybrid world out there, other than to save the public health system money?
Yeah, I did 3 terms with Northland DHB, so I know what you mean, Michael, sort of looking from inside the system at that level. Look, part of the reason is they don't want to be. They don't want to be fully funded, because the moment they are, several things will happen. First of all, and again, we're presuming here that they become nationalised and basically the state becomes the single funder. The moment they do that, they'll
and they'll be totally responsible to the state. And secondly, they'll lose their charitable status. And remember, there's several parts to St John's: their training, education, their retail avenues, and they actually want to retain that and retain their autonomy and retain that sense of the community having skin in the game with ambulance, that it's not just a government agency, that actually it's owned by the community. So they don't want to be fully funded.
I mean, I always thought, though, sitting around the board table, I don't give a rat's ass about all those lovely thoughts, Shane. I just worry about getting enough ambulance people to get professionally into me if I'm sick and everybody else into the ED. And there are huge gaps. There are huge gaps throughout New Zealand. First of all, for our ambulance service and for the services they provide, aren't there?
Yeah, this is what I observed as well. When I was ramped at Waikato along with half of the ambulance fleet that night, that was a real observation. And we know that ramping, and for those who are listening, those that sort of may not understand that, it's where the ambulance turns up and the hospital can't receive you. So you become a waiting room in the car park. And you're ramped effectively. And we were covering from Taupo to Mercer, and half the fleet were just sitting behind the steering wheel because we couldn't offload patients into the ED. So I worry about that as well. We had very serious patients. There were very serious patients out in the community that we couldn't get to. But there we were ramped, and it was part of the observation. I had a sense, I knew from the questions I'd asked the Minister that this was going on, but you can't actually beat being there and talking with the crews and watching and understanding and actually being on site. That's a real life experience.
Now, I hope when you're Minister of Health you continue to do that, actually go out, go into those EDs, because it seems that sort of practical day-to-day experience or night-to-night experience, it's what's missing from our policymakers and our politicians, yeah?
Look, I think pretending that you know what's good for New Zealand, particularly rural and far-reaching New Zealand from Wellington, is just wrong. It's just not possible. You cannot know what's good for the people of North Hokianga looking out your Wellington window. And, Tony Ryle used to just turn up at hospitals. And there's some that say, well, your governance not operational, you should have had the CE, you should have let the board chair know, whatever. But Tony just used to turn up and just say, hi, I'm the Minister of Health. How are things going today? And you really can't beat that. I used to see that with after hours when you were called to, for example, a rest home for an emergency. You really got to see how well that rest home was operating, because they had no time to plan, they had no time to bring all the dignitaries around or whatever. You just saw them in that moment and were able to make a view as to whether it was working well or not. So anyway, Tony used to do that, and I have every inclination. Again, I don't want to cross boundaries that I shouldn't cross, but every inclination to be that person that's accessible to the workforce so they know that they've got my ear.
At the end of the day, mate, we elect you and we pay you to do the job. So if that requires stepping on some management toes, I don't think we care, do we?
Yeah, I think New Zealanders would give me leeway too. If someone says, oh, Shane, you should have actually called the board, the CEO, the senior manager, the locality coordinator, before you turned up at a hospital, I'm kind of thinking, nah, I think New Zealanders are happy for me as a potential Minister of Health to turn up and say, hey guys, what's going on today? How can I help? I think I'd get leeway.
I think your assessment's spot on. All right, now, before we go to Northland, just staying on this issue of our public health system, which we all appreciate is in crisis. And it's in part one of the reasons we shut down New Zealand from COVID was because our primary part was we believed we didn't have a public health system that could cope if things got bad. And, the implications of that socially, economically are huge, as we both know, 3 years on from that particular event. I'm thinking now, I've seen your desire to have a new medical school at Waikato. But in interviewing people, I see that the first graduates won't come out for 8 years. So that's not going to be an immediate short-term solution. Increasing the number of students at Auckland and Otago, ditto. It will be less than 8 years, but it still won't provide you with that workforce. You're still reliant, surely, Shane, upon getting workforce from overseas in the immediate and short and medium-term future, aren't you?
You are absolutely right. Firstly, when you say we all know it's a crisis, everyone except Andrew Little and Asher Verrill, so just qualify that. They refuse to call it a crisis. Let's be in no doubt it is a crisis, so just to set that context. But you are absolutely right. There's a short, medium and a long term to our health workforce. And the most immediate is our immigration settings. Goodness only knows why we didn't turn on that day one pathway to residency for nurses until so late that we did.
Yeah.
But yes, immigration, we're going to need to reach offshore. But let's be real, they've now gone to Australia, they've gone to Canada, that international pool that we could have reached to, that's a lot less than it was 1 year, 2 years, 3 years ago. So it might sound nice as a soundbite, but actually doing that is going to be quite hard. Secondly, we've got what I call the Uber docs. They're the docs I met in Auckland who have got deep international experience. They've passed their medical council exam, and for some reason, we can't find them the 2 years apprenticeship, the PGY1, PGY2. We can't find them those places in our hospitals, so they drive Uber Eats in Auckland. Why would we do that, Mike? That
I agree.
Makes no sense to me whatsoever.
Well, I can tell you know, and I know why. It's because of the restrictive nature of some of our specialist medical facility or organisations in this country, isn't it?
Oh, we need to open that up. They can't cry that they don't have health surgeons to accompany them on the ward round and then prevent those health surgeons from training.
Absolutely.
You can't have it both ways.
Yeah.
We need to open that up, and we have nurses too who, for whatever reason, can't complete their CAP course. And credit where credit's due, this government has funded part of that CAP course, which has opened that tap a bit. But my point being is we have people who have passed their New Zealand exams, particularly doctors, who are driving taxis. We need to fix that. We need that to the workforce. And then your other question is the long term, which is, you're right. The Waikato Medical School will take in its first graduates, its first entrants in 2027. This is a long-term way to address the health workforce. But, if everyone just said, that's long-term, we'd never make a start on opening the tap on our new doctors and nurses. And that's what's happened. That's what's happened over the last 9, 10, 12, 15 years. Everyone said, that's a long-term play. Let's just look at the stuff in front of us. And we never actually grow enough of our own homegrown, culturally competent doctors and nurses. So we're putting a flag in the sand. We're saying several things. We're saying, Auckland and Otago, you've told us you can only take 50 each. You'll max out at that. Please, here's your 50 Otago. Here's your 50 Auckland. Go, God bless you. Grow some doctors. And then what we're also saying is that we need a new style of medical school, that the 6 years like I did isn't the modern way to train anymore. So we'll be a graduate entry. You'll come in with your undergraduate degree.
Excellent.
We'll train you over 4 years.
Yep.
And then secondly, that we'll have a rural focus. We will train you in the taupos, the tikawitis, the Tokoroa peripheral hospitals, send the trainers out there with a model of care. So imagine I go to Auckland and train for 6 years. I join the squash club. My partner joins the board of trustees. And then you tell me I'm going to work in Tokoroa? I don't think so. But if I train you in place, if I train you in Tokoroa and commit to you that every day of your training, you will be back in your bed with your family in your community, surprise, surprise, you stay there. So train in place, stay in place. That's the model of care, Mike.
Okay, well, let's talk about that very quickly, because one of the things that's obvious to me, and it's obvious to you, you're a smart man, you've not just as a doctor, but you've also as a politician and a district health board member. You will know that whoever you train in New Zealand, whether they're nurses, whether they are radiologists, whether they are specialists, whether they are GPs, out there is an international community that is voraciously wishes to consume as much as we do. Australia, Canada, United States, Great Britain. Is there some sort of bonding operation that you can bring into our medical workforce so that we can at least keep the people we train in this country?
Yeah, so you're exactly right. Retention is really important, and we know several things. We know that there's several thousand nurses who have registered, New Zealand nurses registered in Australia. We know that Australia said they're going to bring up a $1.4 billion health army. Where do you think that's coming from?
That's right.
We know there's about 350 New Zealand students who are going through Australian medical schools because they couldn't get places in New Zealand. So retention is really important. Part of the policy we brought out a month ago was around nursing. And it said we would bond nurses for 5 years after they graduate in return for halving their student loan. So we've looked at where our biggest gap is, which is these 4,000 nurses said, we want to offer you some relief during your student years with knowledge that you'll get student loan relief if you stay in New Zealand for 5 years afterwards. Now, there is a bonding scheme for docs. It's a little bit more complicated and not that popular. Part of that reason is, as a doc, there's so much after hours to do, you can make good money as a junior doc. Why would I take on a restriction when I could buy myself out of that in, a month's work if I needed to? And so the bonding doesn't work that well for docs. There is actually bonding for vets and nurses and a few others as well. But we're actually going to be looking at providing support during the student years and then bonding 5 years afterwards for nurses. So it's not a concept that we've put aside. Push the doctor bonding further back into the student years rather than more at the graduate where it is at the moment. So we're certainly up for that, but it's not popular for that reason. I don't know how to put it nicely, but you make so much money you can just buy your way out of your bond really easily.
Well, don't let them buy their way out of the bond would be the simple answer to that one. All right, Now, second issue, Shane. This morning you would have read in your New Zealand Herald as well that the ethnicity-based health policy is being used in Te Tai Tokoro or Northland, despite the government saying that it wouldn't be, and that it has been used for urology and orthopaedics in that particular area. Your reaction to that?
I'm very unhappy about that. I was very unhappy when I first received news of the equity adjuster, which was about a month before it came into public domain. So I'd been approached by a number of clinicians saying, Shane, we are unhappy about this. And so I did a range of ministerial questions so that when the media actually took it into public domain, I already knew how it had been deployed, where it had been deployed, that their plan was to roll it out across the country. What happened then was that the minister said no, it had only been deployed in Auckland. Initially she said Counties Manukau, then came back later in the day and corrected the record and said actually Green Lane, I think it was Auckland and Green Lane. And we thought that was it. It now turns out that it's been in other places. I don't like the equity adjuster. I will die in a ditch for health resources being distributed on health need and nothing else as a first principle. I absolutely get the inequities, understand that, don't disagree with it, but you must not shift off health need as your first principle, because I'm telling you, the moment you do, tomorrow you'll decide that the depth of someone's pocket is how you'll distribute resources, and the next day you'll decide their merit to society is how you distribute resources, and you'll go down a slippery slope that is just not worth traversing. You must distribute health resources based on health need first and foremost.
The trial in Northland is based on, as I said, urology and orthopaedics. So that means that if there are two people who need a hip replacement in Whangarei, one assumes that if I'm Maori or Pacific Islander, I go up the list there. I can see that would cause enormous resentment to anybody who is, European or Asian as well. So one would anticipate that would divide the cultures and races quite nicely. As a policy too.
Yeah, this is right, and this is why when Hipkins, when this came into public domain, he told Asher Verrill to pause because he didn't want to create another discrimination by trying to remove a discrimination, is what his statement was. Reality is, it turns out from reporting that actually equity adjustment came in. Remember, he was Minister of Health, came in under his watch. When he was the Minister of Health, this was starting to be worked on. So he does have some ownership of this. My understanding is that you can't move across priority groups, but you can be advanced within a priority group. And so, yes, someone who may be less ill, but maybe a Maori or Pacifica, would be able to be advanced further up, get their surgery done earlier than someone who may actually have higher clinical need. Yep.
Right. So it will go, is the commitment that you're making if you're the Minister of Health.
That's correct. What we've said is that, and what I've said is that I'll base policies on clinical need first and foremost.
Okay. Do you accept, though, a general premise that if I'm Maori, I don't get as much access to public health, or is the problem, and Shane, partly cultural? You see, just to explain, Shane, I'm a 60-plus-year-old man, conservative. So I don't have a tendency to go to the health service quickly as part of my culture, okay? So just 60-year-old conservative me and go, nah, I'll be okay, until, oh, gosh, I've got, grade 3 cancer. Is there something of that, of Maori as well, like, listen, I don't want to go to the doctor? Is there a cultural reason why, for example, Maori and Pacific Islanders might not head into primary care as quick as, Europeans or Asians? I don't know. What do you think?
Look, I think it's multifactorial. I think there's several things, and I pursue this particularly through waiting lists. So you, first of all, need to see your GP. There can be financial barriers, there can be time barriers. Finding a GP, that can be problematic. GP sends a referral into the hospital. Hospital sends you a date and time. That implies you've got a reliable postal address and that it arrives. You get an appointment to see a specialist, first specialist assessment. That implies you can get time off work, that you have transport, that you have someone. There's a whole lot of multifactorial things that come into access across a range of cultures. What is also true, and where I think the solutions lie to this is in having a system that is culturally competent. Let me give you an example. If I see someone who has diabetes, let's say a Maori male, and I start first of all talking about diet, if I don't have the likely matriarch of the house in that consultation, complete waste of time.
Oh, I see.
Because at the end of the day, the guy I'm in front of isn't doing the meals. He's not sorting out the meals and the shopping for the week. So I need to understand that I need actually the matriarch there as well, because she's actually the one who's going to be doing the actions that I'm wanting, and I'd like them to be sort of supportive as a family. That's cultural competence. And so that sense, and I used to see this as a Maori doctor, that Maori would be very comfortable coming to me. I don't believe necessarily my advice was any better or different from a non-Maori doctor, but there was a sense of comfort. They were very comfortable opening up. They understood that I understood their wider social networks and collective networks. And so I think what I'm talking about here is cultural competency. I think if we can have our docs, nurses and organisations more culturally competent, I think we'll address a lot of the inequities that we have, actually.
It's interesting you say that, because my mother used to have an aversion going to Indian doctors. She was a white woman, conservative, quite strict in her views. Had always gone to white doctors, mostly male, through her entire life. So when she got to 70 and she met her first Indian doctor, who spoke in clearly an Indian accent and had come to New Zealand from India, she was a bit hoha, if you know what I mean. Is that the kind of cultural competency you're talking about?
Cultural competency is where people are comfortable sharing their personal lives and their personal stories with the medical practitioner across the desk, so that they will say as much as is required to make the best diagnosis you possibly can. You are comfortable, you've developed rapport, understanding, so that you can reveal your most intimate moments sometimes with that trusted person on the other side of the desk. That's cultural competency. And then from the practitioner themselves, it's understanding I have a plan, there's a pathway here. What is the best way for me and the patient to get that pathway enabled? Who do I need in the room? Who does what? That is cultural competency.
Okay. And finally, I guess, as I said, you've got 3 months to go. Listen, I'm getting an enormous amount of feedback as I talk to you from our texters saying, love your answers, love your directness, things like that. But the issue for you is going to be, my friend, budget. And we both know that. On the one hand, there are a lot of unmet needs out there. The public health system's a classic example of it. And on the other hand, we're not as rich as we are, and this government's been borrowing money and spending money hand over fist. You're going to have quite an interesting conversation, aren't you, with the incoming Minister of Finance, if you are elected the Minister of Health. That's going to be a biggest problem, getting the funding for the programs and policies you want to implement, yeah?
There is. Look, there's several things here. First of all, we said that the portfolios that will get new money are health and education. So both Nicola and Chris Luxon have committed to that. Secondly, it is also true that this government has put more money into health. That is absolutely true. But what I see is more money, more bureaucracy and worse outcomes. And what that means is that there is money around there. I mean, we're hearing the $540 million in soon to expire rat diagnostic.
Oh, that's just dreadful.
How could we let that happen?
That is appalling.
How could we let that happen?
Yeah.
And, you know, I'd seen that before about 2 years ago with measles vaccines. It was $22 million expiring. How could we do that? How could our procurement be so poor? So there are pockets here within the health system that we would do a better job on. I don't believe that across Health New Zealand, the Ministry of Health, that we need 200 PR consultants.
No.
I just fail to believe that.
Yeah.
It's just not possible.
Agreed.
And I'm struggling to think of the 150 million that we spent on consultants last year. Because here's the deal. We do need consultants, but there are some areas of expertise we don't have in the public sector. And when you want arm's length, that's a consultant. That's someone outside of you. Okay, I get that. But here's what I'm going to need from any consultants we do bring in. They will have an obligation, either through the RFP or just as a terms of service, to teach the public sector so we lift capacity. So that we're not got the same problem a month later. I'm not paying you the same amount to tell me the same thing. I need you to come in, bring in your teach the public sector so that our whole level of knowledge rises, so the capacity of the public sector rises. That's the deal if you want to be a consultant under my watch.
Well, and then finally, you and I have both served on district health boards. I think we instinctively sat there and realised what a complete waste of time they were, although we could only really say no, couldn't we? We couldn't really ever initiate anything. We could only say, nah, you're not going to do that. We're not going to go back to district health boards under you, are we?
No, I think the challenge we've got here is that with everything centralised to Wellington, the risk is what we're seeing, that loss of the local voice, and that's the challenge with health systems. How do you get some of the benefits of centralisation without losing the local voice? And we've just gone way too far towards centralisation and layers of bureaucracy. I want to just sort of shout out, though, district health boards did hundreds and thousands of operations every year. They were imperfect. Every health system's imperfect. I get it. And I'd have to say removing inter-district flow changed behaviour in ways that were good. That was just problematic. It was just a compliance morass, and all that happened was you held on to cases you probably shouldn't have because you didn't want to have to pay someone else, and so on. So that has changed behaviour. I think that's been a good thing. But we do need to recapture the local voice. So I will be stepping closer to the regions than what this government has with everything coming out of Wellington.
So does that mean you'll be getting some sort of formal, elected, appointed community groups to offer advice in specific regions or areas?
I'll definitely have community voice at the few layers that I will have. We're working through that at the moment in quite some detail because we've got time, because what I've said to the sector is if we're successful, the day we land, I won't undertake major structural change on day one. And that's really important because the sector's just absolutely shattered. I mean, my own college said, Shane, if you're successful and do structural change on day one, we'll fight you. They're just exhausted. We actually need to build up the spirit, build up the number of people. There's a whole range of things we need to do first of all. But if it turns out that in some short period of time I can't live in someone else's kitchen, I will need to have an alternative plan, and that's what a number of thought leaders are working with me on at the moment. And I'll give you that direction of travel. It will return more voice to the regions.
And finally, as all of the health policy come out from the National Party, or are you waiting a little bit closer to the election day to release your full definitive health policy?
Oh, I have so much good stuff to come out. I've actually had it in the can since the end of last year, and some of it I'm just bursting to bring out. Just bursting. I'm just so excited.
You are excited,
but,
yes.
I am, yeah. Some of these, some of them could be landscape changes. And, kind of good. Announce a $400 million medical school. Yeah, that's kind of good. Some of these are maybe $10 and $20 million policies, and they will change the landscape of New Zealand. And it's little things like that spin my wheels sometimes, Mike. Good on you.
Well, we look forward to hearing from you in that detail very near in the future. And thank you very much for taking your time to spend with us this morning, Shane.
My pleasure. Good to speak with you. Good
on you, mate. You too. That is Dr Shane Reti, the National Party spokesperson on health. He will be the Minister of Health should the National Party Act coalition be elected in 3 months, I think it is, from today. Interested in your response to what he had to say as well. But God, he might be excited about it. He might be on medication at the moment. But can I just say, I would not sleep in his position. Such is the challenge ahead of him. But there you go. I'm sure that was what Sir Edmund Hillary said as well. There it is. Let's knock the bastard off.